I think you're welcome to choose the order. You may want to do it just going down the line here. Do a very quick reintroduction and give us your 5 minutes on what you wish we all knew.
Okay, thank you so much. I feel like Gigi really gave us an introduction already, so I'm not going to spend a lot of time. I'm going to jump right in because I'm going to take the prerogative and opportunity I have to answer, to chime in on a question that was asked, and that was about policy changes that are needed. And the reason I think about policy is because I'm not just a medical doctor, but I trained in public health at the Centers for Disease Control. Worked there for 10 years, and I have to correct Gigi. Although I've been a scientific liaison at NIH, I did my infectious disease training in Denver, Colorado. But I'm connected to NIH now through the work that we do around HIV. But I think about policy a lot. And although you didn't ask me to tell you this, I just wanted to chime in because I do spend a lot of time thinking about it. We need to figure out how to obtain reimbursement for non-traditional providers like PharmDs and physician extenders. These issues, I know they're on the radar, but I don't think they're high enough in the discussion so that we can value and respect the work that these folks do because their role is critical. Second, data sharing. It's very difficult to keep people in care when they're bouncing all around and we can't communicate with each other. Three, we have to eliminate agency silos. We've seen this over and over and over again, but we can't communicate across agencies who are doing the same things. And finally, we have to stop funding. We have to look at our resource allocation and stop funding the same stuff over and over and over again and use our money for new stuff. So that's my soapbox response to that. So thank you for indulging me. The other thing I wanted to respond to was about patients and students. When I was on faculty at Howard, students would frantically run and check the labs before they actually saw the patient. And I asked the students, if you're on my service, if you're pressed for time, please examine the patient if you have to choose between examining the patient and checking the labs. And I think the problem is I was the only one who had that expectation. So we have to change. So thank you for indulging me. The Care Center, the reason we're here to talk to you today, is a medical home for patients with infectious diseases, namely HIV. And we are in Southeast DC. To give you a bit about our patient mix, 85% of our patients have some sort of public health insurance, Medicaid or Medicare. 40% are unemployed. Almost all of them are Black. 40% smoke, and many of them have comorbid conditions, so it's quite difficult. It's a difficult group to manage. But these two champions next to me will give you a lot of information about some of the challenges that we see on the ground. And I had remarks prepared in my head, but the discussion has actually taken me in a different direction. So you can see I've made some crazy notes here for you. I agree with Gigi. I want you to know that I feel that the medical system and the healthcare system is completely disconnected from the community and people on the ground. We don't understand the realities that keep people in care versus out of care. And these are the things that we have to deal with. Low health literacy. I had a patient tell me that she wanted me to wait before we took her blood pressure because she had just eaten a bag of potato chips. I had another patient tell me that she heard that herpes turns into AIDS, and on and on and on. Just yesterday, a gentleman who works at our hospital in the hospital cafeteria told me that he's never even heard of Obamacare and he's never heard of the ACA. So I asked him if he'd ever had health insurance. He said not since he was 18 when he had a children's plan through his mother. So these are the realities I think that we have to deal with, and we have to figure out how to close the gap. I think we're going to share with you some information about patients that we see because I think faces and hearing the stories will help you or help us all close the gap. But with that, I want to tell you three things that you asked me what I wanted you to know. So I probably have a couple minutes left, and I have 1 minute left. She's keeping time over here. Um, Number one, the patients are afraid. When they come into the medical setting, they're afraid, and it's up to us to figure out how to welcome them and put them at ease. Number two, the individualized approach is very labor intensive, but it's necessary, particularly for this 1% that Gigi was talking about that utilizes 50% of the healthcare dollars. I've already talked about health literacy being low. So with these challenges, we have to figure out how to adopt tailored approaches for each patient, whether we go into the house and deliver the medications because they're afraid to come into the clinic, or in one instance, we had a patient that everyone on the team tried to convince to come into the medical setting, and he was too afraid. So I left the hospital and met him on the corner of Martin Luther King Avenue and Good Hope Road and talked to him about his health care, and he came in, and we've had a long history with him. So with that, I want to turn this over to Davita Hudson, who will give you some perspectives about how she navigates our patients.